Hello, everyone, and welcome back to the Psychiatric Mental Health Nurse Practitioner Review course. So we are going to talk about theoretical bases of care. So the biopsychosocial framework of care and recovery is an important component of this. So recovery is the most important goal in the transformation of mental health care over the past 2 decades. There are 4 dimensions for recovery. These include health, home, purpose, and community. How this relates to the psychiatric mental health nurse practitioner is that interventions follow evidence-based practice. We are having a focus on the client and the goal, and it being goal-directed, our care for them, and acknowledging the client's ethnicity and culture. We want to help them to recognize their strengths, set attainable goals, and create hope. We want to educate patients and families and the community about mental health, psychiatric illness, and the management of illness. We want to oversee and guide the nurse in designing evidence-based practice for health information and educational programs that are geared to client learning needs, ability, and readiness to learn. We want to care for people with co-occurring medical and psychiatric disorders, but obviously knowing when to refer out. And principles of mental health recovery are integrated into all levels of mental health care. We have to understand the classification of psychiatric disorders, and this is through the DSM-5. So unlike previous versions, the DSM-5 does not use multi-axis classifications. Instead, it classifies mental illness on the basis of specific criteria that has been tested for reliability when used by mental health professionals, and it emphasizes dimensional assessments. So we're going to transition into the therapeutic nurse-client relationship theory, or interpersonal theory, by Hilgrid Paplow. She was born 1909 to 1999. This was the first significant psychiatric nursing theory, and it is based in part on the interpersonal theory. It sees nursing as an interpersonal process in which all interventions occur within the context of the nurse-client relationship. The therapeutic nurse-client relationship is central to nursing. It is what sort of sets our profession apart from others, is that it revolves really around that nurse-client relationship and having the therapeutic relationship. And it includes phases of the nurse-client relationship. So first is the orientation phase. This is when we are kind of meeting, introducing ourselves. Then the working phase, where we are identifying our goals, exploring those goals, moving towards completing those goals. And then the termination phase, or the resolution component of the relationship. Promoting adaptive responses is the goal of nursing, and behavior represents the person trying to adapt to internal or external environmental forces. When we talk about a therapeutic relationship, this is when a client and a nurse enter into a mutual, interactive, and interpersonal relationship specifically focused on identifying the needs of the client. A therapeutic relationship is really where the focus of the nurse is guiding the client towards their goals. We are focusing on the client's needs using goal-directed theory based and are open to supervision. The therapeutic relationship is classified by genuineness, acceptance, non-judgment, authenticity, empathy, respect, professional boundaries, and it has a specific and sequential phases, which we just kind of covered. An overview of different communication skills that we can use as a nurse, and specifically a psychiatric nurse and nurse practitioner. So you can always print this out if you want, but active listening, this is foundational to the therapeutic relationship. The number one desire of humans is to be heard. And we can do this through things like eye contact, nonverbal cues, and nodding our head while others are talking. We can use the skill of broad openings or open-ended questions. This allows patients to establish direction within the session, and it also allows us to do better assessments, because when we're asking open-ended questions, it makes people kind of talk instead of versus just giving like a yes or no answer. So some examples of open-ended questions are things like, what are you thinking about? what was the reason you blank, or what was the reason you sought help from me today? We can also use a skill of reinstating. So this is when we restate the main thought that the patient has said. This is going to make people feel heard because they're going to be like, yes, that's exactly what I'm saying. So they feel like you understand. And it also can help to clarify important statements. So for example, you said that encounter with your husband made your heart race. And then they will either clarify or feel heard. Clarification is an attempt to make a person's statement more straightforward. So I'm not sure what you meant by that. Could you tell me more? Or could you tell me that again? Different things like that will help to clarify statements so you can better understand what they're saying. So we can use reflection. This is repeating back what was said in a different way and with different words. And this is important in validation. So validating the patient's feelings or ideas. So for example, you were afraid that what you said might have hurt her feelings, and that was not what you meant. We can also use things like focusing or refocusing. This helps to move patients from vague to specific. It helps focus on the reality or a recurrent topic. So for example, you were talking about how you were irritated, you were with your mother. Then we can use things like sharing perceptions. So asking patients if the nurse practitioner's perception of what the patient said are accurate. For example, you are close to tears. This is a sensitive subject for you. Theme identification, so noticing underlying issues that come up repeatedly. We can state things like, the way you talk about your friend reminds me of when you had that episode with your father. Silence. So silence is a really great tool because people naturally want to fill silence, so it can make people talk. Silence can also help to convey support. Sometimes when people are dealing with a lot of emotional trauma and grief, they just want like a little bit of silence to reflect on what they said or what happened. So either one of those could be the outcome or purpose of that. And it communicates interest in a nonverbal fashion. So again, if we're using silence, we're showing those nonverbal cues of, that we're interested, not that we're using silence and staring at the door because we want to leave. Suggesting, so give the patient alternative ideas for a problem resolution. So what are your thoughts to an alternative, such as, and hear what they have to say. And then empathy, really important to recognize feelings. So we can say things like, you feel betrayed, because it helps people feel like we care about them. So a therapeutic relationship has specific and sequential phases. We talked about this briefly earlier. So we start with an introductory phase. We are creating trust, establishing boundaries, establishing the length of the interaction. So for example, if you're seeing a patient inpatient, I'm going to be your attending NP while you stay here. So again, we are adding a timeline to that, providing a diagnostic evaluation, and setting mutually agreed upon treatment objectives. Common client behaviors during this time include things like hesitancy, because they don't know if they can really trust us. They may not give us all the details to do a full assessment and treatment planning. They might have some approach avoidance. During the working phase, this is when we move into identification and exploration. So we are going to clarify client expectations and mutually agreed upon goals, implement a treatment plan, monitor health, undertake preventative health care, measure outcomes of care, evaluate those outcomes, and reprioritize the plan and objectives as needed. And some of the things we may see during this phase are things like transference. So those are the way the client feels about us based on their life experience or previous experiences. This is a normal human thing that happens. We as healthcare providers also have something called countertransference, which is what we feel towards patients based on our life and our past experience. It is only normal for our brains to categorize people based on our previous experiences. So you've probably noticed at some time in your life, if you've been in healthcare, you have patients that just love you for no reason. You're their favorite nurse. They always want to have you be their nurse. And maybe it's because you remind them of their friend or their sister or somebody similar. And same with nursing, right? we see it in nursing where people might categorize patients based on a diagnosis, and that's a negative countertransference. There's both positive and negative, and it can happen in both ways for patients and nurses. We may have patients that just don't like us because we remind them of somebody from their past. So different things like that have to do with transference and countertransference. We can see some resistance to care practices and resistance to change. And the termination phase, this is the resolution phase. We review the progress towards the goals. We establish a long-term plan of care. We focus on self-management strategies. We disengage from the relationship. We're terminating it. So we are no longer involved in that relationship, and we're referring them to other services as needed. It is very common for clients to have resistance to termination, especially if they feel connected with you and trusted with you. It's hard to give up a care provider. They can have some regression of symptoms during this time, and there may be a reemergence of symptoms or problems. So we just kind of talked about this, but let's go a little bit more into it. So transference and countertransference are key concepts of the nurse-client relationship. So transference is a displacement of feelings for significant people in the client's past onto the psychiatric mental health nurse practitioner in the present relationship. So like we talked about, right? Let's say you are a patient and you go into an inpatient psych unit and you have a psychiatric mental health nurse practitioner and they look and have mannerisms very similar to your high school best friend. You may be more willing to trust them and, have certain feelings towards them that you felt towards that friend. In the reverse situation, say you have a healthcare provider that looks like the man that maybe abused you when you were a child. It's going to be very hard for that healthcare provider to create that therapeutic relationship because there is going to be that trauma underlying it that is going to make that patient very hesitant to trust somebody like that or who looks like that because they are projecting those feelings of their past onto them. For countertransference, it's what we as the nurse feel towards the patient. So, and again, it can be positive or negative. So, we are not supposed to have favorite patients, but we are all human, right? So, maybe there's a patient that reminds me of my best friend. It's natural for me to be like, oh, I hope, I want to make sure they're okay today. I want to make sure we're talking inpatient where you're in the same kind of vicinity as them to go check on them and just see, do you need anything? And maybe give them a little bit more attention than other patients. And it's important that we're aware of this because that's how we can catch it and try not to do it, right? Because these are normal human, our brains are programmed to categorize things. This is how we survived in the wilderness many years ago. So signs indicating the presence of countertransference include things like, and again, this can be positive or negative. So intense emotional reactions, positive or negative on the first contact with the client. Recurrent anxiety or uneasiness while dealing with the client. That would be a negative. Uncharacteristic carelessness in the interaction and follow-up with the client. Difficulty empathizing with them, resistance to others treating or interacting with the client, preoccupation with or dreaming about the client, requesting, running overtime or cutting time short with the client, depressing or other strong emotions during or after the interaction, depressing or other strong emotions during or after interacting with the client, feedback from others with over-involvement with the client, and frequently running overtime or cutting the time short. So the psychiatric mental health nurse practitioner is expected to monitor his or her own reactions to constantly assess for the presence of countertransference because like we talked about, it is a normal human thing. If identified, countertransference is usually dealt with through the supervision process and in talking to coworkers about the issue. So we can provide it in peer-to-peer or peer-to-supervisor relationships, and it can examine interpersonal dynamics inherent to the PMHNP's relationship with clients. So now we're going to switch into developmental theories. So growth, change, and development are a life process for humans. Humans develop uniquely from simple to complex. The health states of individuals and families can be viewed over a continuum of development. Developmental stages and the milestones give insight into age-appropriate behaviors, measures, level of comprehension for the clients, teaching, and providing a context to evaluating assessment data. And for example, the mental status finding of concrete thinking in a 9-year-old client would be normal and expected. However, if you found the same concrete thinking in a 29-year-old client, this would not be normal and suggest psychopathology. So again, this would be a good slide to kind of print out. These are going to be things you want to memorize. You definitely want to memorize Erikson's. So these are Erikson's stages. So you want to, it's very hard to memorize this whole thing. So the big things you want to memorize are what the stage name is, the years in which that happens, and the developmental task that occurs, and then kind of know what that developmental task is. So infancy, this is birth to 1 year, and this is when you're going to see trust versus mistrust, and it's the ability to form meaningful relationships, hope about the future, and trust in others. If they do not master this skill, things we're going to see are poor relationships, lack of future hope, and suspicion of others. And these are some potential mental health disorders they could be associated with, and then also the associated virtue. You don't need to memorize the potential mental health disorders and the associated virtues, but you should kind of know the other ones. So I'm not going to read those. I'm going to leave them here, but I'm just going to read through what you should really memorize. Early childhood, this is 1 to 3 years. This is going to be autonomy versus shame. This is when they learn self-control, self-esteem, and willpower. And if they don't learn this, they will have poor self-control, low self-esteem, self-doubt, and lack of independence. Late childhood, this is going to be 3 to 6 years old. This is initiative versus guilt. This is where they learn self-directed behavior, goal formation, and a sense of purpose. If they do not learn this, you're going to see a lack of self-initiated behavior, lack of goal orientation, and a sense of guilt. School age, this is 6 to 12. This is when they will find industry versus inferiority. This is the ability to learn new things, a sense of competency and achievement. Doing well in school is going to make them feel that industry and a sense of competency. If they do not achieve this, what we're going to see is a sense of inferiority, difficulty with working and learning. Adolescence, this is going to be 12 to 20, and this is identity versus role confusion. This is a personal sense of identity, seeing the self as unique or integrated. And if they don't have this, we're going to have identity confusion, poor self-identification in group settings. Early adulthood is 20 to 35. This is intimacy versus isolation. We're going to see things like committed relationships and the capacity to love. If people can't achieve this, we're going to see emotional isolation, egocentrism, confusion over who and what they are. Middle adulthood is going to be 35 to 65. This is generativity versus stagnation. So the ability to give time and talents to others, the ability to care for others, and concerns over family and society. If they don't achieve this, we're going to see things like self-absorption, inability to grow and change as a person, inability to care for others, and stagnation. And late adulthood will be 65 plus. This is integrity versus despair. So feeling fulfilled and comfort with life, willingness to face death, insight and balance, and perspectives on life events. If they don't achieve this, we're going to see things like bitterness, a sense of dissatisfaction with life, and despair over impending death. So age of onset of psychiatric disorders, these are kind of important. We should know when we may see the first signs of a psychiatric condition. So in something like an intellectual disability, we're going to see that in infancy and even at birth. ADHD, we're going to see in early childhood, really by age 12. Schizophrenia typically comes out in men between 18 and 25 and in women 25 to 35. Also note, though, with schizophrenia, there can be a prodromal period. So this is the period before the full symptoms. And we'll talk more about this in a later lecture, but sometimes you can obviously see that before because it will come before. So it could be a little bit younger. Major depression is usually late adolescence to young adulthood, and dementia is usually common after the age of 85, although a lot of people are having kind of earlier onset dementias. So let's talk about the psychodynamic psychoanalytic theory by Sigmund Freud. And we all probably heard of Sigmund Freud and his beliefs. Okay, so let's talk about some of them. So this theory is focused on concepts of intrapsychic conflict among structures of the mind. It is initially designed to explain neurosis and high anxiety conditions such as phobias or hysterias. The theory later expanded to include normal and abnormal development and personality development. It assumes that all behavior is purposeful and meaningful. There is the principle of psychic determinism. So this means that even apparently meaningless, random, or accidental behavior is motivated by underlying unconscious mental content. So for example, a person forgets where they parked their car because they really do not wish to go where it was they were headed. So the things we do subconsciously are actually meaningful. That's kind of the thought behind this. All of our actions have meaning. Most mental activity is unconscious. Urges, feelings, and fantasies that would be unacceptable to the person's values if consciously experienced. Conscious behaviors and choices are affected by unconscious mental contents, and childhood experiences shape adult personality. These are all kind of the theories of Sigmund Freud. So he believed that instincts, urges, or fantasies function as drives that motivate thoughts, feelings, and behaviors. So he believed that there are two types of normal drives. And let's just keep in mind, Sigmund Freud is kind of known for some wacky theories. So this is just a theory. They're not true, they're theories. So he believes there's two types of drives in people. One is sexual drive and the other one is aggressive drive. He believed that drives affect behavior as an individual attempts to deal with the associated feelings and seeks gratification through the release of tension that drives produce. Normally, different actions or behaviors are used at different ages to discharge tension from drives and seek gratification. And psychosexual stages of development have been identified to show the age-related behaviors commonly used for discharging drives and obtaining gratification. So Freud has his own stages of development. You should know these ones as well. So we went over Erikson's, now we're doing Freud. So Freud really has four. So the first one is the oral stage. This is 0 to 18 months, and it is based on oral gratification. So for children to accomplish this, they're going to do things like sucking, crying, chewing, feeding. And then he believed that failing to accomplish this leads to psychosis, addiction, and paranoia. Then the second stage is the anal stage. This is 18 months to 3 years. A developmental task is delayed gratification. And to accomplish this, it can be, toilet training. And if patients or people do not do this, it can lead to dysthymia or depression. Then we have the phallic stage. This is 3 to 6 years. And the task is sexual exhibitionism. And it is accomplished by interactive play and pretend play. And failure to accomplish this can lead to sexual identity disorders, according to Freud. And then we have the latency phase. So this is 6 to 16 years. It is about socialization and identity development. And the master of psychosocial skills and motor skills. And failing to accomplish this can lead to narcissistic and borderline personality disorder, according to Freud. So this is a very interesting thing that Freud discusses. I think this iceberg is a very cool way to remember it. So he believed there are 3 primary psychic structures that make up the mind and the personality and are responsible for mental functioning. That is the id, the ego, and the superego. And we're going to go through that. This is a picture of all of them, but we're going to go through. We can see the id is at the bottom in the unconscious level. The superego is in the preconscious level, and the ego is in the conscious, but also at the preconscious level as well. So let's go through it. So the id, this contains our primary drives, instincts, urges, or fantasies. Drives are largely unconscious, sexual, or aggressive in content, and infantile in nature, operates on the pleasure principle, seeks immediate satisfaction, is present at birth, and motivates early infantile actions. The id says, I want. So the id in this picture, basic impulses, seeking immediate gratification, irrational and impulsive, and operates at an unconscious level. So I like to think of the id as like, it can either be like the part under the water in the iceberg, but also like a lion. You know, it's just acting on its animalistic instincts. So the superego. The superego has an ego ideal. It is a sense of consciousness of right and wrong. It contains aspirations, ideals, and moral values. It regulates by guilt and shame. It develops around the age of 6 as children come in contact with external authority figures such as parents, school teachers, coaches, and religious figures. The superego says I should or ought. So we can see the superego is in that pre-conscious level. It has ideals, morals, strives for perfection, incorporated from parents, becomes a person's consciousness. And so we can remember it like the iceberg, or we can remember it like I always think of it as Captain America, because it's called the superego. It sounds like it is a superhuman, super person. So I think of it as like Captain America because he's perfect and ideal and, the ideal right person. So that's just how I remember it. All right, so the ego. This contains the concept of external reality. It is the rational mind that is responsible for logical and abstract thinking. It is adaptive. It mediates drives and environmental realities. It begins to develop at birth as an infant struggles to deal with the environment. It's responsible for use of defense mechanisms. And the ego says, I think or I evaluate. So, and that ego is in that conscious part of the mind, if we remember the iceberg, and it is an executive mediating between id impulses and the superego inhibitions. It's testing reality. It's rational. It operates mainly at the conscious level, but also a little bit at the preconscious. And so I just have a person thinking because I feel like that's what it is. The ego is just, your rational mind. All right, so Freud also believed that the mind has conflict over what to do to achieve gratification. Conflict is usually unconscious, and conflict is experienced consciously as anxiety. The function of anxiety is to alert the conscious mind to the presence of a conflict, and conflict is normally dealt with through the use of defense mechanisms. So they're a function of the ego, they're unconsciously called into action, they're used to reduce anxiety, they become part of the personality, they maintain a sense of safety, promote self-esteem and well-being, can be used episodically or habitually, and may be used constantly and become fixed as seen in neuroses. So these are the different defense mechanisms. So let's go through them. So the first one is denial. And denial So these are the different defense mechanisms. So the first one is denial. And denial is an avoidant of unpleasant realities by unconsciously ignoring their existence. For example, a partner denies the evidence of an affair. The next one is projection. So this is unconsciously rejecting the emotionally unacceptable personal attributes, beliefs, or actions by attributing them to other people, situations, or events. So for example, people might say, all men do this. You might hate someone, but your mind tells you that such hatred is unacceptable. So you solve the problem by believing that they hate you. Those are both signs of projection or types of projection. Then there is regression, and this is a return to a more comfortable thoughts, behaviors, or feelings used in earlier stages of development in response to current conflicts, stressors, or threats. So for example, a child might revert to thumb sucking or bedwetting in response to a new stressor, such as a new baby or a new school. There is repression. So repression is the unconscious. So there's the best way to think about this is because there is repression and suppression. So repression is unconscious. Exclusion of unwanted, disturbing emotions, thoughts, or impulses from the conscious awareness. Then we have reaction formation. So this is an overcompensation. So unacceptable feelings, thoughts, or behaviors are pushed away from the conscious awareness by displaying and acting on the opposite feeling, thought, or behavior. So this can be things like displacing anger feelings with extreme friendliness, but we also see this, when we see disturbing cases where, somebody was a pastor, but then really behind closed doors, they were doing something terrible. That is a reaction formation. Rationalization is justification of illogical, unreasonable ideas, feelings, or actions by developing an acceptable explanation that satisfies the person. So a person who's struggling with alcohol use disorder may say they only drink socially. Undoing is a behavior that attempts to make up for or undo an unacceptable action, feeling, or impulse. So, for example, somebody who is a physically abusive spouse may come home with flowers. Intellectualization, this attempts to master current stressors or conflict by expansion of knowledge, explanation, or understanding. So, an employee sorry, my hair got stuck on something. So for example, an employee who is fired identifies the benefits of the termination for the business to succeed. Suppression, so like we talked about repression earlier, but suppression is the conscious version of repression. So conscious denial of a disturbing situation, feeling, or event. Some people might use humor, so seeking a funny aspect in a stressful situation to reduce the associated anxiety. So a daughter-in-law overhears her mother-in-law complaining about her housekeeping, and the daughter-in-law bursts out and says she can't cook either. Sublimination, this is the unconscious process of substitution of socially acceptable constructive activity for a strong unacceptable impulse. So for example, somebody trying to control anger may begin an exercise program, or a mother of a child killed in a drive-by shooting becomes involved in legislature to change gun laws to help with gun violence. Then there's altruism, which is meeting the needs of others in order to discharge drives, conflicts, or stressors. There's conversion, which is the psychological angst manifested as a physical symptom. So for example, sometimes in psychiatry, we'll see things like abdominal pain, but there's really no reason for it besides, anxiety. And then dissociation is an out-of-body experience that disconnects the person from the physical world. They may appear to be daydreaming or inattentive or freeze during acute stress. So next we're going to talk about the cognitive developmental theory by Piaget. So Piaget believed that human development evolves through cognition, learning, and comprehending. Biological and environmental factors set the course for a child's development. These are done through things called schemas. These are the building blocks of knowledge. Adaptation, which is a process that enables the transition from one stage to another. Equilibrium is a force that moves the development along, happens when a child's schema can deal with the new information by assimilation. And assimilation uses an existing schema to deal with a new object or situation. So for example, an 18-month-old child sees a bald-headed man with a bow tie and immediately starts crying and saying, "No, doctor, no." That's because he assimilated the knowledge that his previous doctor, who had a bald head and a bow tie, so that means all people with bald heads and bow ties are doctors. And then there's accommodation. So when the child is unable to assimilate the new information into an existing schema, they form a new one. So the 18-month-old child's mother explains that not every man who wears a bow tie and is bald is a doctor, because he is not giving the child a shot. The child then learns not every bald-headed man with a bow tie is going to give him a shot. So Piaget's cognitive developmental theory, this is high yield. So this, along with Erikson's and Freud, like these are all important things to know. So he described 4 stages of cognitive development. So the first is the sensory motor. This is birth to 2 years. The achievement of this stage is object permanence. I'm not sure how to say it. This is the ability to understand that objects exist independent of the child's involvement with them. If the child cries, they have not mastered object permanence. So if you take an object, so let's say this notepad, let's say this is the child's toy, right? And I move it under the table so the child can no longer see the toy. Somebody who has not mastered object permanence will think that it's just gone forever and they will cry. Like if they can't see it, it doesn't exist. Whereas somebody who has mastered object permanence might walk around and look under the table to see if that object is still there. Object constancy allows us to trust that our bond with those who are close to us remain whole even when they're not physically around. With object constance, absence does not mean disappearance or abandonment. So similar to object permanence, object constance is related to relationships. So means when the child cries when someone goes away or separates from them because they feel abandoned. So this is something that usually people with borderline personality disorder have not mastered. And that's why they feel like if people aren't with them or are out of, are somewhere else, or they get into a fight, they feel like they're gone forever. And there is that abandonment kind of wound there. Then there is the pre-operational phase. This is 2 to 7 years. It is more extensive use of language, symbolism, and you're also going to see magical thinking. You're going to see egocentricity. So with difficulty taking the viewpoint of another. So they can really only see things from their point of view at this age. They cannot see things from another's point of view, but they will have magical thinking, and this is normal. Thoughts can influence things around them. So if you have a child who's 5 years old and comes into the hospital and says, I'm a princess and there's fairies in the world, and right, that's normal development. That child is not psychotic. That child is having magical thinking. You also want to keep that in mind. This won't be on the test, but just I thought of a situation. You also want to keep in mind people's developmental stages. So if you have somebody that is 11, 12, and they're having magical thinking, but they have the mental capacity of a 5-year-old, that's going to be normal for them, right? So keep those in mind too. So concrete operations is the next stage. This is 7 to 12, and this is when children begin to use logic, develop concepts of reversibility and conservation. They can understand concepts like conservation. So if you take a plastic cup and you heat it, even though it may expand or change its shape, the properties of the cup will not change. Reversibility, this is the realization that one thing can turn into another and then back again. So for example, water can turn into ice and then go back into water. Conservation, this is the ability to recognize that although the shape of an object may change, it will still maintain characteristics that enable it to be recognized as an object. So for example, clay. And another example, so 4 quarters is the same as $1, which is the same as 100 pennies. That is going to be when somebody masters concrete operations. Formal operations are going to be 12 to adulthood. This is the ability to think abstractly. Thinking operates in a formal, logical manner. Being able to apply abstract logic. So if someone can test a hypothesis or do a scientific project, that's going to require abstract logic, as well as things like conducting algebra. So that's going to be formal operations. So exam tip for Piaget's, do not go by the ages of the patient because you might have a 15-year-old in the sensory stage. Different for kids, so go by the presentation. Sometimes ages can be misleading. So like we talked about, you may have an 11-year-old, but they may have the developmental, or they might have the intellectual ability of a 5-year-old, right? So if they are displaying magical thinking, then they are in that pre-operational stage, or whatever it is. If they're asking about Freud or whichever, right? So don't always go by the ages. I mean, keep them in mind, but remember the task and to look at the presentation. Then we have Interpersonal Theory by Harry Sullivan. So these ones, most likely you're not going to see, I mean, I don't want to say never, but like the big ones are Freud, Piaget's, and Erikson's. So we'll go through these though quick. So interpersonal theory: behavior occurs because of interpersonal dynamics. Interpersonal relationships and experiences influence our personality development. Understanding behavior requires understanding the relationship in the person's life. There are two drives to behaviors that Harry Sullivan believes. So satisfaction, basic human drives such as sleep, mating, and hunger, and security, so conforming to social norms of a person's reference group. When the person's need for satisfaction and security is interrupted by the self-system, mental illness occurs. These again are theories. Humans experience anxiety, and behavior is directed towards relieving the anxiety, which then results in interpersonal security. And Sullivan also describes stages of interpersonal development. So here are some interpersonal theory by Harry Sullivan. These are his developmental stages. In ways similar to Freud, right? So you have your infancy, birth to 18 months is that oral gratification, sucking, chewing, crying. Childhood is 18 months to 6 years with delayed gratification, toilet training. Juvenile is 6 to 9 years, forming of peer relationships, where we see that interactive play and pretend play. Pre-adolescence is 9 to 12 with same-sex relationships, so gender-specific play. Boys, rough and tumble play or shooting games, and girls play school and house. Early adolescence is 12 to 14, opposite sexual relationships. And then late adolescence, 14 to 21, self-identity development. All right, so there is that one. Then we have the hierarchy of needs theory by Abraham Maslow, and we remember this from nursing school, right? Maslow's hierarchy of needs. It is a health model rather than an illness model. It gives an organization of needs and hypothesizes that certain needs are more important than others. And it states that a person will attempt to meet the most important needs first before they can satisfy others. So we remember this probably from nursing school. At the bottom is our basic needs. We first have our physiological needs, our food, water, warmth, and rest. Above that, we have our safety needs like security and safety. Those are our basic needs. Then we can start to focus on our psychological needs. So belongingness and love, so intimacy, relationships, and friends. And then esteem needs like prestige and feelings of accomplishment. And then self-fulfillment needs and self-actualization, so achieving one's full potential, including creative activities. And again, so when we have patients come in with psychological needs, we also need to look at their basic needs. Do they have stable housing? Do they have food? They need those things before they can really start to focus on their relationships and going to therapy and all of those types of things. When patients cannot meet their physiological and safety needs, they usually meet criteria for hospitalization, which will provide for both basic physiological and safety needs, and a sense of belonging can develop in the milieu. So if they're in an inpatient unit with a milieu, that can help create a sense of belonging. Partial hospitalization programs are continuous day treatment programs in patient intensive outpatient programs. These focus on the needs of belonging as the patient gains functioning of self-esteem. And then vocational rehab, psychodynamic therapy, psychoanalysis, patients can work through that self-actualization. That's kind of how Maslow's relates to different types of psychiatric care. Then we have the health belief model by Marshall Becker. This is a conceptual framework to explain health behaviors and guide behavioral interventions to promote health. So some words that are important to this theory. So perceived susceptibility. This is one's beliefs regarding the chance of getting a condition. Perceived severity. So their belief about how dangerous the condition would be if they got it. Perceived benefits. So one's belief in the efficacy of the advice to reduce the impact of this disease. Perceived barriers. Their belief about the barriers to the disease and getting help for it, cues to action, so something that activates or enhances the readiness to change or implement the new behavior or stop an existing behavior, and self-efficacy, so one's confidence in one's ability to successfully perform the health behavior change. We then have the social change theory. So this is based on Lewin's change theory by Kurt Lewin. And behavior is defined as a dynamic balance of forces in opposite or in opposing directions. It often is used in management change, organizational implementation, and quality improvement. So there are 3 steps to the model of change. So this is when you're doing like a quality improvement project. These are kind of the things that are going to happen, the behaviors of individuals involved. So you're going to see an unfreezing, a change, and a freeze. The 3 major concepts, so this includes driving forces. So these are forces that move the organization towards the direction of change, causing a shift in the balance towards the change. There's also restraining forces, so an opposing force to change that pushes the organization in the opposite direction. And then equilibrium is a driving force. So if restraining force and no change occurs, the status quo remains. So the 3 stages. So first is the unfreezing. So this is identifying and assisting with letting go of old counterproductive patterns. So you've probably noticed anytime there's a change, there's always resistance to change. Even if that change is going to make things so much better, there will always be a resistance to letting go to the old way of doing things. So that is the unfreezing. Then you're going to have the change. So thoughts, feelings, and behaviors, or all 3 will begin to change, become more productive with the new situation and belief that the new is better than the old, and then a refreezing where the change is established as the new status quo. We also have the trans-theoretical model of change. You've probably seen this in nursing school at some point, and these are the stages that individuals go through when they are changing or debating a change. So we first have the pre-contemplation stage. This is where the person is not even thinking about changing. They don't want to change. The action for this is to provide information and feedback to raise the person's awareness of the problem and possibility of change. We do not give prescriptive advice. So if we have a patient that is not even thinking about changing, they're drinking a lot of alcohol every night, we want to talk about things about like, the health impact of drinking that much, the signs and symptoms of withdrawal when they stop drinking, how it can potentially be dangerous. They can have seizures, things like that. So we want to educate them, but we do not want to push a change on them because they're not even thinking about a change. When it comes to contemplation, this is when the patient acknowledges that they have a problem and they intend to take action, but they're really only thinking about it. They're not committed to changing. So during this time, we can help the person to see the benefits of changing and the consequences of not. During the preparation phase, they've taken some steps to plan. The person has made the decision to change and is ready for action. And we can help them by finding a change strategy that is realistic, acceptable, accessible, appropriate, and effective. Then the action phase is when the person is engaging in specific overt action to change, and we can support them and advocate for them and help them accomplish the steps for change. The maintenance phase is when the person is engaging in behaviors to prevent relapse. So we can help them to identify the possibility of a relapse and identify and use strategies to prevent relapse. And then important to note that relapse is a part of the change cycle. So we can ask when was their last relapse, what led to it, what are their plans for getting past this and avoiding another relapse, and what keeps them from relapsing. This is going to help the person to take a holistic look at the situation. So then we have motivational interviewing. So this is a therapeutic technique to get people unstuck and encourage a health behavior change. It attempts to elicit the client's internal motivation for change and to frame the benefit of change in a manner congruent with their values. It's focused on goal-directed therapy. It builds on the trans-theoretical model of change. Its motivation is elicited from the client. It is non-confrontational and non-opposing discussion. We want to listen with a patient-centered, empathetic approach and empower the patient. The patient must understand that they are in control of their actions and that the changes they desire will require them to take the steps towards the change. So when we are doing motivational interviewing, so again, we are asking questions to help the client come to their own decision about making the change. So we want to listen for things that they say. Some of these things are, for example, a desire to change. So the client expresses a preference for change. So I would like to, I want to, I wish. The ability to change. The client makes statements about their capability. So I could, I can, I might. We want to listen for reasons of change. So making specific arguments for the change. So I would probably feel better if I, and then a need for the change. So they might make statements expressing an obligation to change. So I ought to, I have to, I really should. They might also express a commitment or tell of an action they had taken in the direction of a change previously. There are then 4 principles for motivational interviewing. So we want to express empathy, radical acceptance, reflective listening, ambivalence is normal, and use the client's own words using that kind of reflection. We want to develop discrepancy. So amplifying from the client's perspective, the discrepancy between their present behavior and their desired goals. So for example, say you have a patient that, is really focused on being healthy. They're going for runs, they're eating really well, but yet every night they drink a bottle of wine. We might point out to them, you've stated that an important goal in your life is to have really good health. And I can see that through, your dietary decisions and your exercise regimen. But then I see that you drink a bottle of wine at night, and just kind of see what they say back. That's going to be kind of a developed discrepancy. We want to roll with resistance. So we don't want to argue. We don't want to directly oppose resistance. We want to invite new perspectives. And the client is the primary resource for solutions, signals, the therapist to respond differently. And we want to support self-efficacy. So the therapist expresses a belief in the client's ability to make the necessary change when they are ready. So the basic skills of motivational interviewing, this is the ORS. So we want to ask open-ended questions, give the provider the opportunity to learn more about what the patient cares about, their values, their goals. So for example, I understand you've had some concerns about your drinking. Can you tell me about that? Versus, are you concerned about your drinking? So the ORS for communication. So we talked about open-ended questions, affirmations, reflections, and summary. Some other tools are decisional balance guides, readiness rulers, asking about extremes, and exploring past successes. And again, the fundamental principles of motivational interviewing, which we just talked about, but you can remember that through the acronym DARES. So develop discrepancy, avoid arguments, roll with resistance, express empathy, and support self-efficacy. So we had kind of talked about asking open-ended questions. So the next one is make affirmations. So we can take the form of compliments or statements of appreciation and understanding. This helps build rapport, validate and support the patient during the change, and most effective when the patient's strengths and efforts for change are noticed and affirmed. So example, I appreciate that it took a lot of courage for you to discuss your drinking with me today. Or you appear to have a lot of resourcefulness to have coped with these difficulties for the past few years. Those are all affirming statements. We can use reflections through rephrasing, encouraging personal exploration, and help people understand their motivations fully. And it can be used to amplify or reinforce the desire for change. So for example, you enjoy the effects of your alcohol in terms of how it helps you unwind after a stressful day at work and helps you to interact with friends without being too self-conscious. But you are beginning to worry about the impact of drinking is having on your health. In fact, until recently, you weren't too worried about how much you drank because you thought you had it under control. Then you found out your health has been affected and your partner said a few things that made you doubt that alcohol is helping you at all. So again, we're reflecting back all of those things that the patient had told us. And we can summarize. So this ensures a mutual understanding. It links discussion and checks in with the patient. It points out discrepancies between the personal and current situation and future goals. And it demonstrates listening and understanding of the patient's perspective. So for example, if it's okay with you, let me check that I understand everything we've been discussing so far. You've been worried about how much you've been drinking in recent months because you recognize that you have experienced some health issues associated with alcohol intake. And you had some feedback from your partner that she isn't happy with how much you are drinking. But the few times you tried to stop drinking have not been easy, and you're worried that you can't stop. How am I doing? So this is how motivational interviewing is different than traditional counseling. So motivational interviewing is really based on that the patient is the expert on themselves. It is based on partnership. It forms a therapeutic, collaborative relationship with the client, completely respecting their personal experience and autonomy. It uses elicitation by assuming that the drive and resources for change are intrinsic to the client as demonstrated by their perceptions, goals, values, and attempts to evoke them. And is based on independence, affirming that the client's lived experience and their inalienable rights to life, liberty, and the pursuit of happiness. Where traditional counseling has kind of a parentalism approach, it assumes that the client has poor insight and judgment and not sharing the therapist's views, uses a lot of instruction. So it assumes that the client lacks sufficient knowing of how to make necessary changes and requires the expertise of the therapist. And they use this term SAGE, so the provider is the expert who insists on the best course of action. So that is the, therapist on stage approach. So self-efficacy and social learning theory by Albert Bandura. So this is behavior is the result of cognitive and environmental factors. People learn by observing others and relying on role models. Self-efficacy is the perception of one's ability to perform a certain task at a certain level. This is based on their confidence, so ability that one can engage in the behavior change in various situations. Temptation, so the likelihood of engaging in unhealthy behaviors in various situations. Something called the importance ruler. So on a scale of 1 to 10, how important is it for you to make this change? 1 being the least and 10 the most. And a confidence ruler. So on a scale of 1 to 10, how confident are you that you are able to make this change? And again, those are how we can kind of scale the importance and confidence. And behavior change and maintenance are function on the outcome expectations and efficacy expectations. So the process of change. So this first starts with consciousness raising. So discovering and accepting facts in support of healthy behavior change. A dramatic relief. This is experiencing negative emotions such as fear, anxiety, worry that goes along with the unhealthy behavioral risks. Self-reevaluation. So incorporating behavior change as an essential feature of one's identity as a person. Environmental reevaluation, so recognizing the positive impact of healthy behaviors on social and physical, environmental, and or recognizing the negative impact of unhealthy behaviors. Self-liberation, so making a firm commitment to change. Helping relationships, so developing social supports for healthy change. Counter-conditioning, so liberally substituting a healthy alternative behavior or cognition for an unhealthy behavior or automatic thought. Reinforcement management, so implementing a reward structure for positive behavior change and reducing rewards or aversion reinforcement for unhealthy behaviors or transient lapses. Stimulus control, this is an important one, reducing environmental cues to engage in unhealthy behaviors and adding cues as reminders to engage in healthy behaviors. So for example, if somebody struggles with drinking alcohol and, if they go out to a bar, that is like a big place they like to drink, stimulus control would be choosing to not go to a bar and instead maybe join like a group or something. Maybe you go to AA or maybe you join like a board game group where there isn't drinking, something like that. Social liberation, so recognizing social norms have changed in the direction that supports the desired healthy behavior. And then relapse prevention. This is a social cognitive model describing risk determinants of relapse. High risk situations are situations that immediately precipitate to relapse. So negative emotional states, these can be things like negative emotions like anger, anxiety, depression, frustration, loneliness, and boredom. Could also be an interpersonal conflict that causes people to relapse. So with significant others, family members, romantic interests, supervisors, etc., or social pressure, direct or indirect environmental cues, or being around the vice. So positive emotional states are associated with substance as a solution or enhancer of well-being. That is a reward for a day's work or a seductive advertising. Coping strategies, this is the person's response to a high-risk situation. Effective is leaving a high-risk situation, positive self-talk, calling a friend, planning another activity, contingency planning, or avoidance of high-risk situations. And then ineffective things that people might do is use the substance as a coping strategy, lingering in a high-risk environment, and minimizing potential harms. There is abstinence violation effect. This is the cognitive restructuring in which the lapse is distinguished from a relapse and seen as an isolated mistake. So if people relapse, that doesn't mean they relapse forever. We can look at it as an isolated mistake. People make mistakes. How do we move forward past it? And how do we resume that abstinence behavior despite those negative feelings about the relapse? Or the client decides to negate sobriety and attempts to quell negative emotional state by future relapses. So we don't want that to happen. So the probability of relapse, a high probability, comes from a high-risk situation plus ineffective coping strategies plus poor self-efficacy leads to a lapse, and then an abstinence violation effect leading to the relapse. A low probability, so if a person is in a high-risk situation, they can have effective coping strategies that increase self-efficacy and decrease the probability of a relapse. So just a few more nursing theories. We have the theory of cultural care by Madeline Lingener. Regardless of cultural care is the unifying focus of the essence of nursing. Health and well-being can be protected through cultural care. Culture provides the context for care and meaning for suffering. It's based on values, beliefs, generational influence, gender roles, and religion. Then there is the theory of self-care by Dorothy Orm. This is based on self-care are the activities that maintain life, health, and well-being. The caring theory by Jean Watson. Caring is an essential component of nursing. There are curative factors that guide the core of nursing and should be implemented in healthcare. They are those aspects of care that potentiate the therapeutic, healing, and relationship. So moving on to the biological premise of mental illness. So biological means age, race, sex, weight, comorbid conditions, toxins, infections, medication, nutrition, hydration. Psychological is resilience, history of abuse, neglect, trauma, parental attachment, self-efficacy and self-esteem, automatic thoughts, delusions, perceptions, neurodevelopmental stages, aspirations, coping mechanism, therapeutic alliance, and transference. And social and environmental includes housing, safety, relationships, financial resources, educational resources, accessibility, support systems, legal status, and cultural assimilation. And you might remember from your schooling this kind of biological, psychological, sociological, environmental, and then predisposing. So things that predisposed them to this, precipitating things that are leading up to it, perpetuating things, making it worse, and things that are protective. All right, so that is the end of this discussion, and I will see you guys in the next one. Thanks. Bye.